PowerPoint, let's hope.
So we're going to start with mechanical ventilation, and just that it's basically, it's not just a fancy air compressor. It has a lot less PSI. We're going to talk about the goals and objectives of mechanical ventilation. Our objectives are to promote safety, so alveolar recruitment, minimize shunting. We want to minimize the tidal volume, but yet give the patient what they need. And we want to maximize compliance. Those are some of our objectives. We want to promote comfort. We want the vent to do the work for the patient. We don't want to make their work of breathing worse. We want to work on synchrony. So if we're synchronizing with their ventilation, we're making their work of breathing a lot less. They're not having to work against the vent. And then this is something we don't get into much, but it's promote liberation, which is basically your weaning process. This vent is known to be used for weaning, but it's not something that we're going to do in transport. So, but that's kind of the end goal. And what we do in ventilation, even early on with transport, can shorten that time that that patient's on the ventilator. So we can affect that process, even though we're not doing it. We still have some effect on it. Ventilation. What are our goals of ventilation? So one is to get rid of CO2, correct? How do we measure CO2? With end-tidal and ABGs. How do you affect it? How do you change end-tidal CO2 or CO2 exchange with the ventilator? FiO2 will affect oxygenation but won't affect their CO2.
No.
CO2 is your rate and your tidal volume. And from watching the online videos, you guys saw that this vent in ASV mode works with percentage of minute volume. So when I was going through this, I'm like, you know what, I'm not real familiar. I mean, we know, but like, let's break it down. So respiratory rate and tidal volume give you your minute volume. So then I was kind of wondering, like, how do they come up with an ideal minute volume? Like, how do they know that I should breathe 7 liters a minute or 8 liters a minute, or like, how do you figure that out? So I found that it's your ideal body weight. And how do we figure out ideal body weight?
Height times sex.
Height times sex. And you guys saw in the video that the Hamilton is based on centimeters. We have changed that for you. It's inches now. Yeah. So you don't have to do that conversion factor as well. You just have to plug it in inches. And then if they're male or female. And then the coefficient, so what you multiply it by for an adult is going to be 0.1 liters per kilo, or I like it better, 100 mLs per kilo. Mm-hmm. So if you have a 70 kilo patient, what's going to be their minute volume? 7 liters per minute. Okay? If they're less than 30 kilos, it's going to be 0.1 to 0.2. And if they're 3 to 5 kilos, it's going to be 0.3 liters. So they need a little bit more. Oxygenation is the other goal. So how do we monitor oxygenation?
SpO2 and gases.
Yep. And how do we affect oxygenation?
Turn
Heat.
Turn up CO2 and increase your heat. Yep.
Yeah, it's right there.
So I said, you guys don't have the excuse of no coffee. All right. So I threw this up there because of the test. So how do you know? Because I know
should
that
have had that up there for the test.
So I've been on that transport before where you're like, gosh, do we have enough oxygen? Are we going to run out? Do we need to take an extra D-tank? Because I know I've been on transport where we've taken extra.
I do it on my phone.
Yeah. So for us in the EC145, we have locks. So that creates another issue on top of it because you have to do a little bit of extra math. So if you were going to figure out, let's say that we come in at the beginning of the shift and they tell us we have 5.4 liters in our locks today. So I have a patient that I'm going to run at 15 liters. What you're going to do is first you need to convert it from locks to gas. So you're going to take that 5.4 and you're going to times it by 860. And then after you get that, which ends up being 4644, you divide it by your 15 and you get 309.6 minutes, which is actually a little over 5 hours. This is the question that I said Grant would know, but if you had a D-tank and you wanted to figure out how much you were going to have in your D-tank, if you would have enough, how do you figure it out, Grant?
You take the, well, first of all, you're supposed to subtract 200 PSI from your gauge.
To make
Because you
sure
always
it's
want to
not
make sure you have
anaerobic.
residual, because it takes like 200 PSI to push the oxygen out. But anyways, you take the PSI times the conversion factor, whichever cylinder you use.
So let's say you have a full D tank at 2,000.
So then it'd be like,
2,000
it'd be like
times-
3,200 liters of gas.
So you take the 2,000 times the 0.16, or
Mhm.
subtract the 200, so 20 or 1,800 times the 0.16.
Mhm.
And then let's say your patient's running at 2 liters,
Then you just divide
divide it by 2.
by 2.
And that'll tell you how many minutes you will have, and then you can convert that to hours. So yes, I added that in there for those purposes. The nice thing about this vent is it does tell you how much oxygen you're using. So it doesn't know how full your D tank is, but it does tell you what your oxygen consumption is. So you can figure that out once you get them on the vent if you're worried about having enough oxygen. So then we're going to get into modes of ventilation. We're going to talk about the basic ones that we use right now. Peace Transport and MedFlight both use the LTV 1200. So our modes that we use are SIMV, whether it's volume or pressure, and assist control and pressure control. So what is assist control? Well, in assist control, you're basically giving, for every patient breath, you're going to give a set tidal volume. So your tidal volume is always the same. It doesn't matter what your patient compliance is, they're going to get that same tidal volume every single time. And the things that we can set on the parameters for assist control are respiratory rate, tidal volume, PEEP, we can set our I time, our FiO2, and the trigger. For pressure control, we're going to set a pressure, and it's going to be a number above PEEP. So if our PEEP is set at 5 and we set it at 20, it's going to be 25. So once the circuit senses that you've reached that pressure of 25, then it's going to cut off the breath. Well, the problem with this one is that you don't have the same tidal volume every single time. So based on your patient compliance of their lungs, that's going to determine what your tidal volume is going to give you. And the parameters we set with this would be your respiratory rate, your pressure control, PEEP, I time, FiO2, pressure support if you're in SIMV mode, and then your trigger. So SIMV, this is one that I know I use a lot because I figure if I paralyze my patient and take them out, it's basically putting them in assist control anyways. So with SIMV, if you set a rate of 12, it's going to make sure that those 12 breaths are whatever tidal volume you set. But then it's going to allow the patient, if they're breathing 20 times a minute, it's going to allow them to take those other breaths and just get whatever they pull. So let's say you have a tidal volume of 400 set, and for those 12 breaths, they're going to get that 400, but they're breathing 16 times. Those other 4 breaths, they might only get 300 mLs or whatever they pull. So in this one, we're going to set our respiratory rate, so kind of your backup rate, your tidal volume or pressure, depending on which one you want to use, PEEP, I time, FiO2, pressure support, and then your trigger. And we're going to get a little bit more into what each of those mean. So pressure ventilation versus volume ventilation. This just kind of gives you a real quick look. With volume, your volume is always going to be constant, but your pressures are going to vary. But it's more stable when it comes to minute volume ventilation because you're making sure that they're getting a certain rate and they're also getting the volume that you set. In pressure, the pressure is more constant, but then your volumes are going to vary, so it's not quite as accurate with minute ventilation. And then we're going to get into ASV towards the end. So how do we pick the number for our tidal volume? What do we use?
There's 6 to 8 milliliters.
Based on
Ideal body weight.
ideal body weight.
Yeah.
If we do this incorrectly, let's say that we set it too low, we're going to hypoventilate our patients. If we set it too high, then we can cause barotrauma and some other bad things that we don't want to happen. And basically you want to attempt to keep your PIPs less than 30 is kind of the goal, I think, depending on what's going on with your patient. So respiratory rate. let's say that we have a 22-year-old that overdosed that has perfectly healthy lungs, and you want to pick a respiratory rate. They've been bagging for the half hour it took you to get there, and now you're going to put them on the vent. How do you decide what rate to set?
Go by normal standards for respiratory rate.
Yep. If they're a normal, healthy lung, don't need extra special whatever, then you're gonna wanna go ahead and just set the standard, and then you're gonna look at your numbers and your gases, and you'll determine from there if you need to change things. Now, if you have a patient who came in who was hypoxic originally, let's say that CPR was done on the streets for 15 minutes and they did the homeboy ambulance and threw him in the car and drove him here, and you're gonna intubate.
That's not on video.
It's on video, okay? I worked ER for many years here, so I get it. Anyways, how do you know, what would you set your rate at? Are you gonna set them at a normal rate? Right, so they're probably gonna be hypoxic, so you wanna make sure that you set them at a higher rate, and then you're gonna wanna watch your patient, watch your numbers, and see if you need to bring that number down or what you need to do. So you'll change that. The other thing is that can impact your rate is your IE ratio. How do we figure out, if I set an I time of 1, how do you figure out what your E time is?
Or how many thrusts you wanna give them a minute.
It's based on your breath. So if you set a really high respiratory rate and you still have an I time of 1, you're in trouble because you aren't allowing enough exhalation time, and you could get stacked breaths and you get into some barotrauma. So just being aware that normal IE ratio is 1 to 3, 1 to 4, and as you increase your rate, you need to make sure you're watching your I time and make the adjustments as needed. So physiologic PEEP. Our bodies naturally create PEEP with our epiglottis and our pharynx. Normal is about 3 to 5, and PEEP helps keep those alveoli open for recruitment and oxygen exchange. So PEEP is real important, but what happens when we put a ET tube down their throat? We take away their PEEP. So that's why you should set PEEP, because people normally have 3 to 5. So I know MedFlight in general, we usually set everybody at 5, just as a starting point. I will tell you, I know that Dr. White down in ICU is using higher and higher PEEPs. And I know in the beginning it started to freak some of us out. We're like, what, are you kidding me? But research is showing that it's actually more effective. So getting that recruitment and oxygenation. So just don't be alarmed if you're seeing PEEPs of 10, 12, correct me if I'm wrong, maybe even higher.
I've been higher.
So
I've seen 20.
Yeah, which makes us really nervous because we've been taught, you don't go up, above 8 or 7, 8 for us used to be high, and now we're seeing these high PEEPs coming. So just be aware that it's not uncommon, especially pulling them out of our ICU, that they may have them, and I've seen it other places as well. So setting the PEEP, again, 5, and this is just going to get recruitment, and just watch that you don't have some over distension though. What happens if you give too much PEEP, or what's one of the things you got to worry about when you start increasing your PEEP? It decreases the cardiac output. So you might start to see some hypotension, and that's one of the things you need to take into consideration. Is there another way that you can achieve what you want, maybe with lowering your PEEP a little bit? So watch for your blood pressures. Even just intubating somebody and putting them on a vent can cause some decreased cardiac return, so you've got to watch your blood pressures really close. Setting the I time, we kind of talked about this. Typical I time is 1 second. Just make sure they have enough time to exhale. What about the asthmatic? What do you need to do with them maybe?
Make their I time short and their long E time.
Yep. So.
And they might not need PEEP because they might be
Yeah.
air trapping already.
Yep.
Right.
So, setting your FiO2, our goal is to make sure that it's greater than 94%. Checking your blood gas, looking at your PO2. If you got PO2s 200-300, you need to start weaning down that O2, because oxygen toxicity can affect the surfactant in the lungs. So it can be bad as well. So just making sure that we're not leaving it cranked at 100%, weaning them down pretty aggressively. Pressure support. This is kind of one of those things that I would always say, people say, what's pressure support? And I'm like, oh, it accounts for the dead space in the ventilator circuit. Because I was repeating what everybody else said, but I didn't really understand the whole concept of what it was. So basically when a patient takes their own breath, if you think about it, they're sucking in through that straw. So what pressure support does is it says, oh, they're taking their own breath, so I'm going to give them flow. And it actually puts flow into the circuit to make it easier for them to take that breath, and it decreases their work of breathing. And then trigger is the amount of effort required to trigger a spontaneous breath. This was another one of those. We hear trigger all the time, but does everybody really understand what it is? In modern ventilators and on this ventilator, we use flow trigger. So what this is going to do is it's going to sense, like once you reach that, as they take that breath in, and it reaches that -2 centimeters of water or whatever you've set it to, because that is something we can adjust, it's going to recognize they're taking a breath, and then it's going to start giving them that flow. Adaptive support ventilation, what is it? Well, it's a pressure-controlled minute volume guaranteed mode. So this vent is pretty smart. It kind of looks at the whole picture, and it says, well, my patient's compliance and the rate and the pressure that I'm going to give to, and the tidal volume I'm going to give, I want to achieve this minute volume that you've set. So that 7 liters per minute in the 70 kilo patient, it looks at all those parameters and it gives the patient what they need to achieve your target minute volume. Does that make sense? Mm-hmm. So if you have a passive patient who's doing absolutely nothing, they're intubated, they're sedated, they're paralyzed, their minute volume, if you set 100% minute volume, they have no rate, right? So the vent is going to figure out, okay, to give them the minute volume that you've set based on ideal body weight, I've got to give a rate of this along with a tidal volume. But where the patient comes into play in this part is it also senses their lung compliance. So we talked about in in pressure modes that it just hits that pressure and then it shuts off the tidal volume. But with this one, it actually will reach that pressure, but it will give the appropriate tidal volume. So it can tell your compliance in the lungs, and it can adjust either your rate or the pressure to achieve the tidal volume that you want for your minute volume. One way I think about this too is like we're standing up, I'm standing here, and I have a certain compliance in my lungs, but what happens if I lay down? My lungs will become less compliant. So our bodies normally do this. This vent can sense that. When you move your patient, you change their position, you put them on their side, it can detect the change in the compliance, and it will adjust your minute volume. It'll adjust your rate and your tidal volume and your pressure to give you that ideal minute volume still. So a lot of times on transport, we set them up on our settings, and I know for us, we change their position, we put them upright a little bit, we do whatever. Yeah, they're on a vent, but let's say now they have a little bit of secretions. Well, if they're not coming out of the tube in the aircraft, I don't really know that they have increased secretions other than what my vent's telling me. So, but this vent is sitting kind of back here behind my hip. So unless I'm looking at it constantly or I hear it alarming, which we do, but it may be a minute or so into it. So I'm not making those changes right away, whereas in ASV mode, it's going to sense it with every single breath and it's going to make those changes. In an active patient, it goes more into a pressure support mode. So the patient is determining their minute volume by their rate and by their compliance and by their tidal volume. And what the vent does in the pressure support mode is it just gives them pressure support so that they don't have to work so hard. And if it senses that it's not achieving your target minute volume, it will increase the pressure support or increase the pressure to give them your tidal volume or the minute volume that you want. In your passive patient, and I was trying to think like how can I relate this to like SIMV, or we're pretty focused on, okay, my pH is low, my PCO2 is high, so I can adjust my rate or I can adjust my tidal volume. So we are manipulating the minute volume, but we're looking at it as, oh, the PCO2 is high, let's raise the rate. So how can you look at it in a passive patient with changing your minute volume? Well, if their PCO2 is high and their pH is low, you want them to have more minute volume, right? Because you want them to blow off that PCO2. So you want more air in and PCO2 to come out. So I guess kind of the way I think of it is like, okay, so my PCO2 is high, I need to increase my minute volume. And they recommend increasing by 20%. When you go up, it's up by 20%. When you go down by 10%. So vice versa, if your PCO2 is low, then you want to decrease your percentage of minute volume. In an active patient, if you notice they're starting to have to work harder, they're doing a little bit more effort on their own, you can give them more pressure support by increasing their minute volume. And then it should take some of the workload off of them. The nice thing about this vent is if you have an active patient and let's say I'm getting ready to walk out the door and I don't want them pulling that ET tube out, so I increase their sedation and now they're only breathing 6 times a minute. Whereas before, when I first put them on it, they were breathing 16 times a minute and they were doing a lot of work themselves, so they were in pressure support mode. But now I've increased their sedation because I don't want them to pull that tube out. So I've increased their sedation. It's going to recognize that, and it's going to recognize the patient became more passive, and it's going to go into more of a pressure control mode. So it senses it automatically for you. So this has some increased synchrony kind of advantages to it, is that it makes respirations a lot easier for the patient. Makes it a lot more comfortable. Do you guys have any questions about this part of it? I know it's a lot. I think it'll make more sense once we get into the hands-on. We're going to talk a lot more about it when we get to that part. So these are just some words that you're going to see because how the Swiss define certain things and how we define certain things are a little bit different. And we weren't quite able to change all of the labels on these. So ETS is something that you're going to be able to adjust, and it's called expiratory trigger sensitivity. And it's the percentage of peak inspiratory flow at which the ventilator cycles from inspiration to exhalation. We'll get a little more into what that is exactly, but I think it was defaulted at 30%, 40%.
So,
I
no.
should have looked.
We have it, I think, at 30.
I thought it was 25.
It might be
25.
25.
That's right.
Yeah.
Most vents are 25.
It's at
Should
25.
Be 5 to 25 is typical.
So, and then the other thing is flow trigger, and I talked about that. It's the patient's inspiratory flow that triggers the ventilator to give a breath, and this is something you can change as well. If you make it a higher number, it's the patient's going to have to work harder to trigger the vent. So you want that number a little bit lower so that they're not having to work as hard.
That's the one that road noise and bouncing down in the ambulance can
Yeah.
set it off.
Can trigger.
On the
it.
LTV, it seemed like 2 to 3 was kind of a good
That's
number,
about
but this
standard.
one seems to be around 5. They say.
So it depends
So
on
it just
your.
depends.
It depends on your kid. So if I have an infant, I'm going to go like 0.1 to 0.3. If I have a smaller child, I'm going to go from 1 to 3. If I have an adult, I can go 3 to 5. So that's typical.
That's all it's-
What a typical setting is, and then you just kind of watch your patient, what they're actually doing. Are they?
And you can change it. You can
yeah.
adjust it.
Oh, yeah.
So
Yeah.
just because it's defaulted, we set all of these vents are exactly the same. Whether Pete's Transport or MedFlight, they are all set up exactly the same. So if we're down in ER and you guys are down there and want to help us with that, hey, we're more than happy to let you help.
I've played with your vents
Yeah.
once.
I know you have. So that's what I'm saying. Like, feel free to jump in and, hey, I got this for you because you're really busy. P-ramp. This is something I was like, what the heck is this? Pressure ramp, which you said is also called.
So it's called rise time.
Rise
Rise
time. It's the time required for an inspiratory pressure to rise to the set pressure. So the time it takes you to take that breath in. So the shorter that time is, the quicker it's going to give that breath, that inspiratory phase. Or if you lengthen it out, it's going to be longer. So, and then PASV limit, it's the maximum pressure to apply in ASV mode. So we talked about that this vent looks at your pressures and to give you your tidal volumes. So this is when we're hearing the LTV alarm, high pressure, high pressure, high pressure, because our patient's pressuring at 30 and our alarm's set at 30. This is kind of the same thing that we'll sit there and like turn it up a little bit. But just kind of an FYI, if you're getting a lot of alarms, this is defaulted at 30, and your alarm is set at 40. Yes, that's the way we did it. So you can also change that if you need, if you're getting a lot of alarms, and your patient warrants it needing to be changed. So kind of just a real quick overview, what's the point of ventilation, or what are we targeting? And it's your acid-base balance for us. You're wanting to make sure that your ABG, their pH is correct, looking at your PCO2, at your PO2, and also the very important correlating your end-tidal CO2 when you draw your gas to make sure that your targets are appropriate. How much change in your pH happens if you change your PCO2 by 10? 0.08.
Very good.
So
I get a star.
star for you. Have a chocolate.
All right.
So yeah, that kind of gives you an idea if your patient is acidotic and you know, they're 0.2, you know, let's say 7.2, how much do you need to change your PCO2 to achieve that 7.35? And then basically just looking at your patient, making sure that you're looking at the correct mode. I can see MedFlight using ASV a lot, and us liking it once we get to know it. So just make sure that what's going on with your patient, that it's appropriate. You still might need to use a, you know, a pressure, straight pressure or straight tidal volume mode instead of using the ASV, and just making sure you're always looking at your patient over and over again and making sure that you're doing the right thing. Do you guys have any questions? Not too painful?
Are we gonna get a copy of this?
Yeah, so we were talking about it a little bit.
It's
I'm
better.
gonna need some reference here.
I think